12年。 Good morning. If everyone will come in and take their seats, please, and we'll get started. He's right about questions, though, because you're going to have to turn them.
Turn around and see who's wanting to ask a question.
Oh, yeah, we do, don't we?
Leo's going to help me out.
Yeah.
Hey, how you doing, Madam Chair? Good to see you.
Well, we want to thank you, everyone, for coming to Athens. Already, we've been treated so well here in Athens as we convene the last of our major committee times. And so, with that, I'm going to turn it over to my able co-chair, Mac Jackson.
Well, we just want y'all to know we had you back.
Thank you, Chairman. And we will make sure that we turn. If you have questions, we'll make sure that we get you in order. And Leo's over there going to help us too with that. So let's pray before we get started. Heavenly Father, we thank you for this day, Lord. We thank you for this opportunity to do the business of this great state, Lord, that you blessed us with. And we ask for your wisdom, your guidance, and your leading. In Jesus' name, amen.
Amen. Thank you so much for that. We're going to call on Representative Houston Gaines to come forward and give a welcome to us and any of the local officials. And, of course, we're going to ask Houston to introduce the president of this great university.
Several of you last night, and it's great to have the Rural Development Council in Athens. And I do think today is certainly one where we will remember our friend David Ralston. Today was a year ago. It was a year ago today that he passed away. I think it's important and meaningful that y'all are meeting on that day and meeting in Athens, a place that Speaker Ralston loved. And certainly he enjoyed many football games here and always enjoyed the chance to go to a lot of football games and sit beside him. I know he's going to be making sure we beat Tennessee this weekend. So he's focused but he certainly loved the Rural Development Council and was instrumental in this group. And I want to say thank you for the great work that you've done, Chairman Green and Chairman Jackson, and the entire committee. Y'all have done a great job going across the state. I had the chance to be at the Statesboro meeting as well and kind of hear some of the work that you're doing. I'm looking forward to the recommendations of this committee as we convene here in just a couple weeks, but really for the regular session in January, which we all hope, obviously, Georgia will be in the national championship on the first day of session once again. But thank you all again for what you do. Welcome to Athens. It is a great place to be. And certainly I think the University of Georgia is a key component of that. We are extremely lucky to have an incredible president in Jerry Moorhead. He's been my friend since I was a student here at the University of Georgia. I had the chance to meet President Moorhead when I was a freshman in college and have had the chance to stay friends over that time. We worked together when I was a student body president here at the University of Georgia very closely. And I see he's smiling. I think he's probably remembered some of the times where we disagreed. But no, but we've just become incredible friends, and the University of Georgia is incredibly lucky to have President Jerry Moorhead. He has led this institution to incredible heights, done an amazing job. He is student focused, and I saw that firsthand when I was a student here, that he cared about what students thought here at the University of Georgia. He cared to make sure that the student experience was a positive one, but he's made such an impact across this state. And so y'all are fortunate to hear from my good friend and certainly an incredible president, 22nd President of the University of Georgia, Jerry Moorhead. Thank you, Chairman.
Thank you.
Well, thank you, Houston. And I want to echo his remarks because he was a president I worked with very early in my presidency. And I've had the privilege of just having a string of outstanding Student Government Association presidents to work with on solving issues that are important to students. And this year, their focus has been on adding pickleball courts, which some of you may be familiar with, and we just got that worked out earlier this week, adding 12 new pickleball courts. I never knew that young people loved pickleball as much as they turn out to do, but apparently they have learned by playing with their parents and grandparents and didn't want to give it up when they came to college. So we've been working on that. I want to thank Houston for the leadership he provides in the local Athens community. We have a lot of challenges in this community, and he always steps up and works with the university as we try to navigate all of the local politics in this community, and has been a strong ally for the University of Georgia. So thank you so much for your leadership. And I couldn't help but also think about David Ralston today. David and I were law school classmates, and we were partners on the national team in law school during our third year in law school. And I appreciated throughout his life an enduring friendship and support for not only me, but for the University of Georgia. Like all of you here today, the University of Georgia is committed to ensuring the success of rural communities and doing what this institution should be doing as a land-grant institution to ensure that what goes on here helps the state of Georgia, and particularly helps rural communities across this state thrive and improve in every way possible through the work we do here in teaching, research, and public service activities. And I want to just talk to you a little bit this morning about some of the work that we're doing to support Georgia's agricultural industry. For example, our faculty in the College of Agricultural and Environmental Sciences, they're conducting cutting-edge research that's promoting prosperity for our farmers and agribusiness. The UGA has recently established, as many of you know, because you have helped us with this project, the Institute for Integrated Precision Agriculture, which is now helping farmers across the state harness the power of technology and big data in the work that they do as farmers. And I think our new poultry science building, which you all helped this institution build, is a perfect example of the importance of innovation in an industry that will ultimately help communities across this state. And I'm looking forward to the great research that will be done in the poultry science research complex that will drive one of the most important businesses critical to many rural communities in this state. You may have heard recently that 2 of our students in that college were recently named Future Leaders in Agriculture by USDA. And we have so many other UGA schools and colleges across this campus, such as the Warnell School of Forestry and Natural Resources and the College of Veterinary Medicine, even the College of Engineering, that are preparing students to contribute to agriculture through the management of timber resources, care of our food animals, design of equipment for harvesting and processing, and so much more. Those are the things that a land-grant university, that's what we're supposed to be doing, and I'm proud that we are doing those things. UGA Extension, of course, is the cornerstone of that mission as a land-grant institution, trying to get the work that we do here out across the state of Georgia. And today, additional UGA resources are available, including the Small Business Development Center, which is assisting agribusiness owners and aspiring entrepreneurs all across rural communities in this state in planning and advancing loan proposals and marketing what they do. Our College of Family and Consumer Sciences recently launched a virtual platform to connect women in agriculture to networking and educational opportunities across this state. And then I would also want to make sure you know that beyond agriculture, researchers in every college and school at UGA are working to strengthen rural Georgia in a variety of ways, from growing tourism to eliminating health disparities, and to encourage our faculty to pursue research in rural Georgia. UGA holds an annual rural engagement workshop now just to bring those faculty together and review the ideas and opportunities that are available to them. This is a multi-session workshop. It gives our faculty a greater understanding of Georgia's rural demographics and trends. It helps our faculty develop relationships with rural community leaders, and it enhances their ability to engage with UGA's extension and public service and outreach networks to support rural communities, businesses, farmers, nonprofits, and local governments all across our state. It also provides seed funding for projects that come out of this annual workshop. And I'd like to give you an example of one of those. It's the Cognitive Aging Research and Education Center, which that's such a long thing to say every time. We now call it the Care Center. And with seed funding from this annual workshop and the work that they're doing, we now have 12 faculty members in fields ranging from medicine and public health to psychology and social work that have created the Care Center on UGA's Health Sciences campus. This Care Center is partnering with Extension, the Archway Partnership, the Augusta UGA Medical Partnership, and what they're trying to do is provide statewide diagnosis, education, and support for Alzheimer's disease and related dementia, while also carrying out pioneering research and providing experiential learning opportunities for our students to work in these critical areas. In addition to its physical location in Athens, the center trains UGA extension agents on Alzheimer's and dementia topics and has created tailored education and resource guides to reflect what is needed on this critical subject in rural communities. They've also implemented dementia-related telehealth services for rural counties across this state. Finally, I would like to mention that UGA is considered a national leader when it comes to rural student success. One of the things that you all know we do is accept the valedictorian and the salutatorian from every high school across the state of Georgia, which is a really focused effort to make sure that we don't miss a community in this state. But it's one thing to bring those students to campus. It's another thing to make sure they stay here and they graduate. And we have now launched just a few years ago, so we're seeing how it has developed in such a short period of time, something called the All Georgia program, which is now serving over 4,000 UGA students that come from rural Georgia each and every year. That program offers scholarships to those students, academic coaching, student success workshops, and many other programs to make sure that our rural students, when they get here, they feel supported, they feel like this is their campus, and this is the place that they want to graduate from. And I hope you can see that with this effort in mind, what we're trying to do is make sure that the students that graduate from here gain the kind of education necessary to go back home to their communities and be leaders in what is going on there. So I hope you enjoy your time here today. I hope while you're here, you get the sense that we want to partner with you, because this is a topic dear to our hearts as the land-grant institution in this state. We have a vital interest in making sure that you see the University of Georgia as the place you can come to for the ideas and the programs that need to be advanced, and that you will see this institution as a partner willing to do what's necessary to advance the needs of rural Georgia. So with that, it's my pleasure to introduce the Vice President for Public Service and Outreach, Dr. Jennifer Fromm. She's going to tell you some of the ways that our work in PS&O is making a positive impact across rural Georgia. I think most of you know Dr. Fromm. If you haven't had the chance to meet her, I hope you will do so today, because she is one of the extraordinary leaders at the University of Georgia. And when she takes on an assignment, it gets done. Please welcome Dr. Fromm.
Well, thank you, President Moorhead. It is wonderful to see you all. Chairman Green and Chairman Jackson, we are honored to have you on campus. Thanks for being here. This morning, when I was getting ready, it dawned on me that in exactly a week, next Thursday, we will be gathering with family and friends, preparing for Thanksgiving and giving thanks for all of our blessings throughout the year. And we all have so much to be thankful for. Like you, we are thankful to Speaker Ralston for his vision and foresight in forming this committee back in 2017. And of course, Terry England and the late Jay Powell were a big part of that, as were so many of you. And we're also so thankful to Speaker Burns for continuing the work of this committee and his commitment to rural Georgia. As I think about the work of this committee from its inception to now, all of us who have watched it feel so much appreciation for your hard work and your commitment to rural Georgia. Y'all have addressed some tough issues: healthcare, broadband access, economic development, infrastructure. I mean, these are challenging issues, and you all have made significant progress and have accomplished so much. And I believe that you all have made a big difference. And that's what we all strive for, is trying to make a difference. So as you left your families last night or this morning and drove up here to Athens, please know that we see your commitment to public service. We see the hard work you put into positive change in rural Georgia, and we appreciate your support for the University of Georgia. And I would be remiss if I didn't acknowledge the tremendous partnership that we have with Chairman Lynn Smith. We, through the Vincent Institute, partner with her committee and the Senate House and Natural Resources Committee on the Environmental Policy Academy. We were fortunate to spend 3 days last week with those full committees. And Chairman Smith, thank you for your partnership on that. Speaking of other things I'm grateful for, I've actually been at the University of Georgia for 29 years and 8 months. And so effectively, I have shoes older than Representative Houston Gaines. During my time here, I've worked for 3 different university presidents, and I will tell you that I cannot think of a bigger champion of UGA's outreach mission than President Moorhead. Our 8 public service units and cooperative extension are really united by President Moorhead's vision and his interest in how we pool our collective resources here to make an even bigger difference in rural Georgia. He challenges us every day to find new ways to use the talent and resources we have to make a difference. And so, President Moorhead, we thank you so much for that support. Tomorrow, you will hear about a number of our successful outreach programs, and you're going to hear from us, but you're also going to actually hear from community members that we partner with and students who are engaged in rural Georgia. You will hear about our 18 small business development centers. I just want to lay some numbers on you. Over the last 5 years, our small business development centers have helped Georgians start 2,100 new small businesses, create 15,000 jobs with $9.5 billion in total sales. That's over 5 years. 13 of the 18 Small Business Development Center offices are serving rural Georgia. And I'll mention one program we started this year with a small pot of federal funds, a digital marketing boot camp for small business owners in rural Georgia exclusively. We've completed 16 of those sessions. The total attendance was 803 people in rural Georgia. So that tells us there's a demand for this. If you're interested, we're just finishing up the programs. We had one yesterday in LJ, today in Rome, and then the last program will be December 12th in Jessup. Tomorrow, you will also learn more about our Archway partnership and how we're engaging UGA's best students and faculty in rural Georgia communities. Last year, we took 300 UGA students to 8 Archway communities around the state: Colquitt County, Washington County, Pulaski, Hart, McDuffie, Spalding, Burke, and Newton counties. So in those communities, students worked alongside community members on issues like preventative health care and chronic disease prevention, downtown revitalization, community branding, and improving infrastructure, all sorts of issues. I want to mention one specific program. Our students worked with the Moultrie Police Department on developing and implementing a co-responder model. And this project in Moultrie won the nation's highest national award for outreach last year. So we're really proud of that. And incidentally, this project was replicated in Washington County, where communities came together. Yay! Communities came together to secure a $1.5 million grant from Governor Kemp to implement a regional co-responder model. So we're really proud of our involvement in that. There's such a demand for more Archway communities that in 2022, President Moorhead supported us in launching something called the Connected Resilient Communities Program. It's basically a way for us to be able to reach more communities, but on a shorter term, limited engagement. So the communities currently participating with us through that Connected Resilient Communities Program include Appling County, Cartersville, Grady County, the City of Sylvester, Newton County, and the City of Thomaston. So if you have a community in your district that might be interested in engaging with us on this program, the requests for applications for it are out now. I think they're due at the end of January, and they're on the Archway Partnerships website. And then finally, you'll hear tomorrow from Rob Gordon's team at the Carl Vinson Institute of Government, and they're taking a statewide lead on helping communities with workforce development and economic development. Vinson has a nationally recognized program. It's called Propel, and it guides communities through a multi-step customized model to develop and implement economic growth plans. We launched Propel with funding from USDA, and we're currently working in Appling, Grady, Quitman, Stork, Clay, Randolph, Pulaski, and Washington counties. And with additional funds, new funds, a small pot from USDA, we're expanding this work to Baldwin, Ben Hill, Crisp, Emmanuel, Marion, and Burke counties. And President Moorhead was kind enough to supplement these funds for us to be able to develop the Propel Rural Scholars Program, where again, we're taking groups of students out into rural Georgia to work with the communities on economic development. So in our first year, we had 15 Propel undergraduate rural scholars. They spent 2 semesters intensively working with community members, and we just welcomed 15 additional students. So look for those undergraduates in your community. And again, Vincent just received a national award for this program, for the Propel program, as a best practice in economic development. As you know, there's quite a demand in rural communities for downtown revitalization. The Vincent Institute is also engaging students in something called its RSVP program, where we're working with small towns on transforming their downtowns. And just to give you a couple examples, in Chickamauga, our UGA student designed District Hill Cemetery Master Plan won a national award from the American Society of Landscape Architects. Ringgold was able to obtain $4 million in funding from DCA and ARC for downtown improvements with the design help of our students. And in Hinesville, students helped the city design park improvements and flood controls, and those improvements will be supported by Georgia Power and a federal grant. So those are just a few examples of UGA's partnerships and work in rural Georgia. We are so thankful to have your support to do this important work. And I'll just conclude here and say that my hope is that at the end of tomorrow's program, you will have 2 takeaways. One, that the work that the University of Georgia is doing in rural Georgia is making a difference. And 2, that we are a great return on investment for the people of Georgia. Please know that our outreach programs are here to help support your vision for rural Georgia. As you travel around your districts and you have communities that would like assistance or partnership, please let us know. That's why we're here. Thank you all again for your service to our great state, and go Dogs.
Thank you so much, Dr. Crum and President Moorhead. We appreciate that. Do we have any questions from the committee while we have these 2 here?
Can we get some contact information?
Raise your hands and we'll get you turned on.
Thank you, Mr. Chair. The last presentation was packed with a lot of information. Would you mind going over the Propel program again? I was writing notes and I missed exactly what that entails and how it benefits our areas. Okay.
If you'll come back to the podium. Okay.
Question. So Propel was started several years ago, really as a coaching model for community leaders, government, community, industry, education partners, really to try to help communities kind of plan for their future. So it's really taking them through a process of engagement with each other, engagement with community members, to really develop a plan for how to succeed, both from an economic development standpoint, but also related issues such as workforce development, economic resilience in the face of downturns, at some point in the future. So it's really think of it as a coaching model, sort of helping educate and train local community leaders on how to develop a plan related to economic development. And then we've been able to, with generous funds from UGA, the foundation in particular, and other funds from USDA, to really put that out in a lot of different communities, and also create this student program that really is really focused on getting students at UGA into our rural communities, getting them to see what rural life is like. See, some of them are from rural communities and they want to go back. Actually, they want to go back and learn more about how their communities work and build a career in their local communities. Some of them might be from Atlanta or other places around the country, but we're giving them an opportunity to work on the ground with our communities, again, around economic, workforce development, community development issues.
So it's both the coaching part, so it's someone that I can bounce ideas as a community off of, what will be best practices in order to take our community from A to B. But also, you have access to a litany of programs that are available to help in the furtherance of that A to B program. So some communities, I mean, you have so many programs with UGA and the Vinson and Fanning and on that communities are not aware of. So it's coaching and providing contacts and resources to additional places that could help our communities.
Exactly right.
Thank
You
you.
said it better than I can. And that's one of the values I think of being a part of the University of Georgia. That's what I think a value of being a part of the Archway Partnership, about the Connected Resilient Community Partnership, or being a part of Propel is that those communities, they don't just get that program. They really get access to all of the resources that we have across the University of Georgia. And so we work hard every day to have connections across the university with expertise, in landscape design or engineering or other places around campus that, again, we're connecting those communities to, or public health or whatever it might be. And then again, sharing best practices among those communities as well. So that's we know each community might answer a question or a challenge a little bit different than another one, but they can learn from each other, and that's a big part of it. Absolutely.
To follow up on Chairman Perkle, we would love to have the names of a lot of those programs and to where we can take them back into our community. What great resources y'all are doing. And we need to really take this into our community. So if we can get those made available to us, we will get the information out.
We absolutely will. We thank you for your support very much.
We've got a couple more questions. Chair recognizes Representative Al Williams.
Thank you, Mr. Chairman. I live in Southeast Georgia, in Liberty County. I'm sure you're very aware of it because the water tastes like cherry wine. But specifically, as Vice Chairman of the Development Authority in my county, it is absolutely mind-boggling how many people think they know workforce development. But we were told this week, because of the Hyundai plant's already 1,300 workers short. And that's not counting all of the peripheral businesses that will come. And we need to engage immediately to develop workforce development in a realistic way. And so that information that you share, you'll be hearing from us because we're late now. And the biggest developments in the state right now in Southeast Georgia and growing daily. We had 22 serious inquiries with our development authority and closed 5 and 4 more in the pipeline that are ready. We need workforce development. We need it from people that know what they're talking about. I'd like to think I'm a great psychiatrist, but I know better. We need your help.
Right. Well, we are there for you and for that issue, absolutely. And we actually just wrapped a conference the last 2 days that was a workforce development conference here in this building with over 300 participants from industry, from education partners, from local communities, really doing that, sort of convening together, sort of learning best practices and creating new ideas about specific solutions to these issues. I'll just mention real briefly a couple of things that we're doing for sure at the Vinson Institute, in addition to helping, specific communities drive ideas around workforce development, things they can do to get words out about different career paths, helping the Department of Education sort of develop career paths with their CTAE program. We're really working to understand the data and the numbers behind, exactly where these workers may come from. And so one of the things that we've really been doing is working with the Department of Economic Development to really do a real assessment of the state. And part of that is data work to really understand, some of the reasons why folks might not be participating in the workforce, some of the issues related to unemployed or underemployed, and really getting at those issues of skill levels, educational attainment, other factors that might be, hindering them from working. But we know that certainly workforce is the critical issue as it relates to economic development.
Thank you, Mr. Chairman. Thank you. This is as much of a well, and along Chairman Perkle's line, Dr. Fromm and you, it just really, I'd love this committee, as a member of this committee, I would love some recommendations from y'all on what we can do better for economic development in our rural communities. I even as a legislature, I'm unaware of a lot of the things we have. We had a presentation about Homerville, I think, last week down with our Policy Institute, and it just seemed like it was some great ideas. They had, y'all done great work, but just couldn't generate enough local economic development to implement a lot of the great ideas down there. And I just don't feel like Chairman Hatchett and Shaw Blackman's not here. We have adequate enough tax incentives for some of our small communities, rural areas. We're spending billions of dollars, committee, on these huge mega projects, and we're just doing a little trickle to some of our rural areas. And I think I'd like to see some bigger ideas or bigger incentives that we can implement this coming session to really kickstart some more ideas in our rural areas. When y'all go in, you do a great job, but it's a lot of other opportunities in smaller communities that I see, even in my district, that the opportunities are there. It's just they need a more of a kickstart to get going. So I'd love some concrete recommendations for that.
Sure.
Chair recognizes Chair Penny House.
Just amazed at all the things y'all are offering. How do you relate all these things? I'm pretty close to my city managers and mayors in the rural areas, and I don't think they're aware of some of this.
Right.
How can we make them more aware? I mean, I can go tell them, but we're elected every 2 years, and I might get beat.
That'd be a mistake on their part.
So how can we continue? How can we continue to let them be informed forever and ever? I don't know if we're getting the word out to them enough.
Yeah, I think we will continue to try to get the word out as best we can. For us, the Vincent Institute, we certainly work really hard to do that through our partners like ACCG and GMA and other folks that we work with. But, I certainly think you can help us as well. So we'll make sure you have all of this information.
So y'all put out the funding information through ACCG.
So we'll put out, we'll talk about the programs that we have and certainly, the availability of all of the services that we have. Those are just one vehicle that we put, the one place that we put that information out. But we work hard really every day to try to continue to put that information out. But it is, we know we can continue to do better.
I'm surprised, like some others, that y'all are doing all this stuff because I was not aware of it, and I do appreciate it.
Sure.
And I will take this to my people back home. Thank
Great.
you.
And we'll make sure you have more specific information for sure.
Amazing resources that you're telling us about this morning that we really do not know about. And so we've got to, in our recommendations, we're going to work out something with y'all to get this information out to our communities and do a better job. Do we have any other questions while we have them there? Anyone else? Thank you so much.
Thank you, Mr. Chairman.
And we really, if you'll leave your information with Leo there, we'll get it
Sure.
out to the committee there.
Thank you.
Thank you so much. President Moorhead, I want to tell you, the other day I had the privilege of dedicating a bridge in Clay County for the third president of the University of Georgia. He went down in South Georgia and there he made his home, and he passed away there and is buried in the cemetery there. And he did a great deal of work after being president at the university in that area there. So that was a great honor for me. Thank y'all for coming this morning. We're going to move right along if there's no other questions.
Again, we want to thank President Moorhead and his staff for the informative information that we received this morning. We're going to go ahead with the rest of our program, starting with community health centers, the FQHCs, and the school-based centers. I believe we got Dwayne Cava, Stephen Miracle, Marcus Garner, and Todd Shipley. Didn't mean to leave out one of the most important people at the Capitol, our friend, Ms. Becky Riles.
Thank you, Chairman Jackson, Chairman Green, members of the council. It is our privilege to be here to present to you this morning about your community health centers, which are located throughout Georgia, as you know, in every legislative district, literally in the state of Georgia. I am speaking on behalf of Dwayne Kafka, who apologizes that he is not able to be with you today, but I will be very brief because what is more important is for you to hear from these members of this panel who do they do God's work every day in serving communities, providing access to health care, and in particular, school-based health centers. But just a brief word about the association. The Georgia Primary Care Association is the member association for all community health centers in Georgia. Every community health center that is designated as a federally qualified health center, an FQHC, as you may hear the term, belong to this association. The association provides technical support. They provide resources, extensive staff to help support the initiation of any new start of a community health center in Georgia, as well as the expansion of services. Each community health center is a 501c3 organization. Georgia has 35 of these organizations. They are nonprofit. They are each governed by a local board of directors, the majority of which are patients of the health center. So who better to know what services are needed in a community than patients of the health center? And as well as other community leaders, bankers, other local elected officials, et cetera. Each organization develops and tries to fit the need of their community. So that's going to vary across the state. What is needed by a health center in North Georgia is very different than a health center in Middle Georgia or South Georgia. So each organization is designed to be able to develop services that are needed. For example, with such a shortage of OB providers in Georgia, many health centers provide those prenatal care services. Many hospitals have come to health centers asking for them to provide the prenatal care services so that when the mom goes to deliver at the hospital, that they know that she has had those prenatal care. She's made those prenatal care appointments and hopefully will have a healthy delivery for that baby. With that, I mentioned 35 organizations. There are 231 clinical sites across the state. And the federal grant dollars that are received by each organization are specifically for the purpose of serving the uninsured and underinsured. Now, that means as a 501c3, they're a small business in Georgia, and they have to figure out how to generate the rest of their operating budget, right? So they serve all patients regardless of their ability to pay, but they are also a significant provider for Medicaid patients, Medicare patients, state health benefit plan. In many parts of Georgia, the community health center is the only provider, and many members are aware of the quality of services that are available. And the services that are provided at a health center include wraparound services such as chronic disease management, case management, etc. Thanks to your generous support over the last 20-something years, you have provided seed money. And these dollars, we call it seed money because it's one-time funding. And so a health center, in order to be eligible for the federal grant dollars, has to be operational. So think of it in terms of if you build it, they will come. But unfortunately, you have to figure out how to build it first. So your seed dollars that you provide for a new primary care site, then a few years later, you asked if we would begin to integrate mental health services and behavioral health services because of the tremendous need, especially in rural Georgia, around mental health, behavioral health, and including our work with the accountability courts to provide medical assisted treatment. And then thirdly, what we'll talk about today are school-based health centers. We learned many things through COVID, not the least of which is when students, as they come back to school, if they're not healthy, they're not able to learn, particularly if they have physical health issues, mental health issues, dental health issues included. So with that, I'm going to turn it over to the panel, and our purpose today is to give you a snapshot of 3 school-based health centers. So keep in mind, these are only 3 of 35 organizations, and each organization designs the model that is needed in their community to also match the demographics of the students that they're serving, the teachers that they're serving, and oftentimes other family members as well. So we'll begin with Stephen Miracle at the far left. My left, your right. He is with Georgia Mountains Health. And then we will move to Athens Neighborhood Health Center and then Georgia Highlands Health Center. And I'm going to let each of them introduce themselves, tell you a little bit about their organization as a community health center, and then specifics about their school-based health center. So, Stephen.
Thank you, Becky. Is this on? Can you hear me? Good. All right. Thank you for the opportunity to share with you our experience and successes providing medical, dental, and behavioral health care through school-based health centers. I'm Stephen Miracle, and I and my colleagues here work at 3 of the 35 community health centers providing care to the uninsured and medically underserved throughout Georgia. Somewhere around 16 of these health centers operate school-based health centers in nearly 100 school locations across the state. My health center, Georgia Mountains Health Medical Group, is based in rural Fannin County, and I serve as the organization's CEO. We began life in 1984 as a part-time clinic with a nurse practitioner working from a renovated trailer in Morganton, Georgia. The clinic was the dream of local political leaders who were successful in receiving seed money funding from the state legislature. We now provide access to care for anyone seeking medical, dental, and behavioral health care through our offices in 4 counties in North Georgia. In addition to our freestanding offices, we operate 2 school-based health centers. Our most recent office opened this past summer in Lumpkin County, a designated rural area. It opened with seed funding from the Department of Education under the Governor's School-Based Health Center initiative. In addition to primary care at these locations, we also deliver behavioral health care to students through our school-based centers. understand that our small behavioral health staff operates with a clinical psychologist, a licensed clinical social worker, and a licensed professional counselor. This small staff provides access to over 43,000 individual patient visits at our office. Our licensed professional counselor actually has an office on site at Lumpkin County Schools. We utilize telehealth services when appropriate, such that students have access to all of our behavioral health providers. Nearly 40% of the students we saw at our school-based health centers were diagnosed with a mental health symptom. 40%. Anxiety and mild depression being the most common conditions. There are several ways that students access our behavioral health services: through parent guardian request, through internal referrals, and through referrals from school counselors. We work closely with school counselors at each of our school systems. The best way to describe our work with these counselors is to talk to you about Tina and Jim. Those who are familiar with jobs in the academic arena know that school counselors play an important role for students. They certainly help students make life decisions on the path towards adulthood. These school-based professionals also help students with issues such as bullying, disabilities, low self-esteem, poor academic performance, and relationship troubles. School counselors can serve as the first line of defense in helping students who are facing mental health issues, and these counselors will refer students to a psychologist or a mental health counselor for further treatment when necessary. Tina is an example of a school counselor we work with who works hard to connect students with resources to help their transition from childhood to adulthood. Last spring, Tina met with Jim, a middle school student at the school where Tina works. Jim expressed concerns about not fitting in with his peers and not living up to expectations from his mom and grandparents. In conversation, Tina, the counselor, learned that Jim's mom is the only parent in the home and that the family was struggling financially. It was discovered that Jim's academic performance had declined from his previous high rate of accomplishment. Tina checked first with Jim's mom and then called our office to set an appointment for Jim with one of our staff. Our commitment, you should know, is to make any student referral from a school counselor a high priority for access to our behavioral health staff. We prefer initial visits to be in person, and 90% of these referrals are seen within 24 hours of referral. The initial visit with Jim went very well. It was determined that Jim needed a follow-up visit the following week. In this case, it was appropriate for the follow-up visit to be conducted via telehealth technology. With Mom's approval, Tina arranged a telehealth visit with our staff. During a break from class, Jim connected to our staff via telehealth from a school office. We later called Mom and reported on the visit. Let me highlight a couple of benefits from this scenario. One, through the school-based health center, professional counseling services are closely connected to student need. Two, Jim, the student, received professional care in a timely manner. Three, Tina, the counselor, facilitated a successful outcome. And four, Mom was able to stay at work and know that her child was receiving appropriate care. Let me take a minute to talk about sustainability. School systems partners with community health centers in part because they know that we are committed to provide care over the long term. Health centers like ours are better prepared than other providers for long-term sustainability for three key reasons. One, our cost structure is lower than traditional providers. We can talk about that more if you'd like. Two, as a nonprofit organization, our focus is on the mission and not on gaining wealth. And 3, we have certain reimbursement advantages not available to traditional providers. I'll end with this. Our model of care addresses a small portion of the behavioral health needs of our state students. There are barriers, but not insurmountable barriers, to expanding access for a larger number of students across the state. Thank you for the opportunity to share how we address the health status for our community.
Thank you, Stephen. Next up is Tionia with Athens Neighborhood Health Center. Local girl.
Good morning. Thank you for having me. You may have seen on your page that Marcus Garner, our CEO, will be here. I am here to replace him and speak on behalf of the Athens Neighborhood Health Center as the boots on the ground. Imagine with me that you're a 12-year-old girl with all of the education and the ambition and the drive to be a veterinarian. But for some reason, you don't have the access to healthcare that you need. And the ambulance is called to your school sometimes 12 to 13 times a year because you don't have the appropriate prescriptions and the appropriate medications. And so you can't thrive. And we all know, and if you don't know, I'll tell you, that students can't thrive, they can't learn when they're hungry, angry, lonely, tired. And if you've heard that acronym before, HALT, I add the additional letter to it, the S, if they're sick. Students can't thrive if they're any of those things. And so that's where school-based health centers come into the fold. And so again, I'm the boots on the ground for the school-based health center here in Athens, Georgia. And it's a conglomerate of the works of the Athens Wellbeing Project. And the Athens Wellbeing Project was an organization that came together to do research in partnerships with the University of Georgia, St. Mary's, Piedmont, all of these other nonprofit organizations to show the data. And the data here shows that on this corridor, in this area of Athens, Clarke County, the students in this area were the most likely to be uninsured. And through a little thing called the COVID-19 pandemic, those insurance rates are increasing. The lack of insurance rates are increasing. What we decided to do with that data is do something about it. A lot of times you have research, you have data, but nothing comes to fruition. So through strategic partnerships with the Athens Neighborhood Health Center, a federally qualified health center, which has been operational in Athens for about 51 years, this Clarke County School District, as well as the Piedmont Foundation, our school-based health center exists. So our goal is not only to speak about the social determinants of health that so many people talk about, but to address the causes of the social determinants of health. We talk about propelling our students, propelling our workforce, but it starts here as a youth. If we don't educate our children, if we don't make sure that they're happy, healthy, and thriving, we can't propel them into the workforce. And so we saw that through the integration of the school-based health center, and we service all of the Clarke County schools, faculty, staff, and students. There are about 12,000 students in the Clarke County School District, and we service all of those. We have seen increase in school attendance. We have seen increase in attendance for faculty and staff as well. We have seen a decrease in the asthma-related emergency events. That young girl that I talked about was our very first patient at our school-based health center with the multiple ER visits, multiple ER calls to the school every year. My colleague here talked about sustainability. Sustainability is being connected to a community health center because of every single reason that you listed. The governor gave a bunch of money to institute school-based health centers, and lots of institutions grabbed it up. But those that are most sustainable are the ones that are connected to federally qualified health centers because of those things that you mentioned. It doesn't matter if you have the health care and the diagnosis, but if you can't afford the medication to treat that thing, or if you can't afford the billing, if you can't afford it, it's not going to help to mitigate the issues or the risks. Again, as we talked about here, we saw in our corridor of Athens that the lack of access to healthcare was increasing over the years. Primary care increases. The lack of access to mental health care increased. The lack of access to dental health care increased. And the lack of access to substance abuse treatment increased. Again, these things are continuing to increase. In Athens, Clarke County, we are one of the poorest counties in the state, but we are masked sometimes by this great institution. And so we wanted to make sure that people were able to see those things that are affecting our children. And again, those are the social determinants of health. So that's the economy, the economic threshold. That's the community and the environment. Those are your access to healthcare and dental care. All of these things affect our children, and we can't learn, we can't thrive without having access to healthcare. So our school-based health center opened in 2019, in October of 2019. And then right after that, a couple of months later, you may have heard of something called COVID-19. We had to shift our model. So our goal initially was to service the students and staff. We're located juxtaposed in between a middle school and an elementary school. And our goal initially was to service the approximately 1,200 students in those schools. With COVID-19, we shifted our model to be able to increase access to healthcare for all, and we started to see any and everybody in the community. We opened our doors to anyone in the community. You didn't have to be a student, a faculty, a parent, or anything like that. We have done countless well checks. We've done countless sports physicals. We have essentially done what school-based health centers have wanted to do, and that is decrease the barriers to healthcare. And one of those things being transportation. 94% of Americans on welfare use public transportation. We are right on a bus line. And so their students, they're able to access us. Most importantly, the students in those two schools in which we're juxtaposed in between, they don't require transportation. Through a partnership with the Clark County School District, bless you, we are able to hire a liaison who works for the school district. And that individual is, again, our go-between for the school district. They help us to make sure that these kids have access to our clinic. Because again, if you can't get to us, we can't help you. Research shows that 19 cents of every dollar is spent on transportation, and that's for all Americans. And that's only second to housing, but less than health and food combined. So people are spending more money on housing and transportation than they are on food and health. And so our goal is to decrease that barrier and increase their access to care. So this is our staff. Again, we're staffed with one family nurse practitioner, a front office staff person, one medical assistant, a dental assistant, and then a dentist. And we are able to provide quality health care in the community. Again, like I said, no matter how good the schools are, students won't be able to learn if they aren't healthy and happy, or if, like I said, if they're hungry, angry, lonely, tired, or sick. And so, like Becky said, we are trying to be that wraparound service, also providing mental health services in conjunction with Advantage, which is a local mental health provider in the Athens-Clarke community. So through strategic partnerships, through a connection with the federally qualified health center, we are hoping that school-based health centers continue to grow, continue to thrive. Our goal is to not replace those efforts of the school nurses, which is a vital aspect of healthcare. Our goal is not to steal patients away from those individuals that already have primary care providers. Our goal is to, again, increase their access to healthcare and decrease healthcare barriers. Thank you.
Thank you, Tionya. Just a couple quick comments. Tionya spoke of how a school-based health center does not replace the school nurse. Those of you who serve on Chair Lady Taylor's Health Appropriations Committee saw that firsthand in Thomasville when we visited a school-based health center. The community health center had their staff there, as well as the school nurse, who spoke about how the nurse was able to be a triage point for students. If a student came to the nurse, then they could determine if that child needed to be seen immediately. And of course, with parental consent, that child is then sent to the health center, which is right around the corner from the school nurse's office. Secondly, those of you who were in Statesboro, and the majority of you took the opportunity to visit East Georgia Healthcare Center and their pediatric and family practice site in Statesboro. So what you saw there, envision taking that and putting it inside a school. That's what each of these organizations are speaking about today. So I hope that helps give you a visual for how this works and how effective it can be for increasing the health status of a community. And with that, I will call on Todd Shiflett with Georgia Highlands Medical Services.
Good morning. Can everybody hear me? Everything they said. My name's Todd Shiflett. I'm the CEO at Georgia Highlands Medical Services. We've been around since 1979, started by 2 Catholic nuns in Forsyth County, when Forsyth County was still 27,000 people in it. Not so anymore. We have about 22,000 patients now. 45% of those are uninsured, 26% Medicaid, 9% Medicare, and the rest are private insurance. Over 60% of our patients are Hispanic or Latino, and 73% of our patients are low income, under poverty level. So that's the demographic that we're serving. We have offices in Hall, South Hall, North Gwinnett, across Forsyth County into Dawson County, Cherokee County, Canton, over into western part of Bartow County. So that area under Stevens territory, basically. We opened our first school-based health center last year. So we're the newbies, basically. Like Athens, we serve a cluster of schools right there, but we're not open to the community, just the schools in that area and the faculty members. Cumming Elementary, Otwell Middle, and Forsyth Central High. Again, I just want to do everything they've said. I don't know if I can harp on anything more than that, but I will emphasize 3 things that I think it's already been said, but I think it's the most important things. The partnership with the school district is essential. And we did a lot of work with that partnership with Forsyth County Schools for a long time before we actually started the school-based health center. Our superintendent actually agreed to be roasted as part of the fundraising efforts to do the startup money for this in the community. Raised a good bit of money. It just kind of shows where we are in terms of our partnership with him and the district itself. It's amazing what you can do when you work together for the common good. Like Becky just said, it's not a replacement for school nursing. It's helping the school nursing. And 3, and this is being a new school-based health center, it's amazing to me how much difference you can make in such a little bit of time. The kids we're making differences with, we're racking up the success stories day by day. And it's amazing to watch, and I'm very grateful for the partnership with the school district to allow us to do this. I did bring somebody from the school district with me to emphasize that. This is Heidi Villa, who is a health service facilitator for Forsyth County Schools.
Yes, good morning. So I'm coming from the school district aspect and having a school-based health center. And I was actually a school nurse for 12 years prior to running health services within our district. So from a school nurse perspective, our school-based health center is just an amazing resource for us. They in no way cover up, or replace a school nurse. We work in conjunction. As a school nurse, I would spend hours trying to find resources for our families to get them just basic health care. Now we have that resource. We have that partnership. So for example, just to kind of put this in an everyday perspective, is that if you have a student who is in the school clinic with 102 fever and possibly have strep throat, we send that child home. With that, there's a hardship. Okay, you have a parent who may lose their job if they have to leave work that day to get their sick child. Okay, they have to go to work. So where does that child go home to? Do they have adult supervision? Are they leaving them in a safe environment? There's that concern. You also have the concern that the parent has no resources to take this child to any sort of healthcare provider. So maybe come Saturday or Sunday, they're actually off from their job and they're taking them to the emergency room, which is for strep throat, not an appropriate emergency room visit, which also contributes to a bigger healthcare concern, right? And so this child is now in the emergency room Saturday night, 10 o'clock at night, being treated for strep throat. And then they're giving a prescription that they can't afford. Okay, so that is where the family is. Meanwhile, that child has missed 3 days of work. You also have the hardship of parents possibly losing income during that. So now we have the possibility that that child can be seen. We do same day sick appointments. So that child can be seen that same day. We also they work incredibly well on that follow-up. You may have a prescription that costs a family, we had this actually this week, that cost a family $82 a month for their child. $82, if you're low income, that's a difference of paying your rent putting food on the table. So we were able to get some coupons, work with some partners, and get that down to a very affordable price for the family. So it's a huge difference to our families. We also work very closely with our McKinney-Vento program. I'm not sure, the MV program, which is a program that serves our homeless children and youth. So we will have a program that we streamline those children if they need to be seen in our school-based health center, which is an amazing resource for these families. And we work with a lot of community partners to even be able to provide what the family is not even, if they're not even able to help with any minimum, we are able to provide those resources, and we work really well as a community. So school-based health centers, if you don't have one in your community, you know, there's funding available through the state, and we're looking for more. So we're working on funding, and we have one in our community so far, but we certainly want them in each, you know, the north and the south end of our county as well. So cannot speak highly enough of school-based health centers and the benefits to all communities.
I believe this last slide is a ribbon cutting of the school-based health center.
Yeah.
So,
Drop some things in it.
Yes.
thank you for that. And Heidi, thank you for teeing up. You know, more funding will result in more school-based health centers. And of the organizations in Georgia and their growth over the last several years, Tionya mentioned that Athens neighborhood has been around 51 years. We have other health centers that have been around even longer, but we are continuing to add new health centers and new health center sites. And I would be remiss if I did not thank Chairman Terry England for that. In helping us with the seed dollars to expand new primary care sites, and certainly appreciate Chairman Matt Hatchett and his understanding and appreciation for community health centers and all of your support through the years. So at this time, we'd like to open it up for questions and let the panel respond.
Thank you so much. We do have some questions. We're going to open with questions from Chairwoman Penny House.
Thank you. The first question is for the first presenter. You mentioned having a dentist. One of the main health hazards in rural Georgia and South Georgia is dental care.
That's right.
And it's not a week that goes by as somebody doesn't call me and have a problem. How can they see a dentist? What are we going to do? It's all about dental care. And how did you go about getting the funds to have a dentist in your federally funded health center? I've been pushing for something for a while, and tell me how you got it.
Can I say we didn't get the funds to have a dentist? So we support our dentists through fee revenue and subsidizing from our other services. We did not receive a grant to provide dental care at that location.
What, don't you think dental care is real important for rural Georgia?
No question about that. We have in LJ, we have a freestanding dental practice with 2 dentists and 2 hygienists. It is primarily sees children. 90% of children use that office. Most of them are underserved. Our catchment area goes all the way to South Carolina, North Carolina, and down to Metro Atlanta because of the need for dental care in rural Georgia. So we made a commitment when we opened our school-based health center that we would find a way to have dental services on site because it is critically important.
Thank you.
And I'd like to add, if I may, Mr. Chairman, Chair Lead Houston, I appreciate your question very much and very committed to work with you to figure out innovative solutions for dental care in rural Georgia. One idea that we would like for you all to consider as a council is the model utilizing a mobile unit for dental services. One of the challenges, not the least of which is recruiting a dentist to rural Georgia, but secondly, in a rural community, as we've heard from some of the previous speakers even before our presentation, one community may not be able to sustain a full-time dental practice. However, if you take a community health center, one I'm thinking of in South Central Georgia, Miss Penny, who has 7 or 8 counties, if they had a mobile unit, which you saw the mobile unit at East Georgia a couple weeks ago, it is the same as a physician's office is the same as a dental office. It has all of the same dental equipment. And so if you could move that mobile unit to a different county each day, then the community would soon realize, okay, on Monday it's going to be in Nashville, and Tuesday it's going to be in Fitzgerald, and Wednesday it's going to be in Lakeland, Thursday in Valdosta. So you see the model that we think may be a sustainable way to provide access to dental services. And as you know, and you've all have spoken to, dental services oftentimes exacerbate other health issues that may be going on for a child or an adult.
Thank you for working with me. One of my passions is this session is to get rural health care, get dental care for rural Georgia.
I'll just make one comment on that real quickly. I do not have dental services, mostly because the business model reimbursement structure is very difficult to make work. There's no Medicaid reimbursement for adults. I have promised Heidi on a number of occasions that we're going to do it in the schools pretty soon.
And I will say, we do have dental services in our clinic, and it's one of our greatest challenges, just because of the high volume of demand for students, the lack of reimbursement, as well as even if the students are insured, some of the community providers do not accept their Medicaid. One thing to think about, another model to think about, and Becky teed it up perfectly, is instead of looking at dental structures and dental grants as our only source of revenue and income, if we think about the gravity of the way that poor dental hygiene affects other areas of our body, then we can seek funding from other areas. Lack of dental health care affects your heart. Let's talk to cardiologists. Lack of dental health care affects your gastrointestinal system. Let's talk to GI people. Let's get as many partnerships thriving and going as we can. So instead of it looking at as one system, looking at as an entire system, an entire mechanism of action for the body.
Chairman Burkle.
Thank you, Mr. Chairman. And I knew that Chair Lady Houston was going to mention something about the dental. As soon as it came up, I saw her writing down. So, Mr. Miracle, my question is addressed to you, and I don't know if I heard it wrong or wrote it down wrong, but I wrote down that you had mentioned that when you started offering mental health services in your school-based health center, that you found 40% were diagnosed with a mental health disorder of some type. And that number seems inordinately high. The numbers I've looked at were anywhere from 10 to 20, but that's still a pretty good bump. Do you think that is geographically limited in your area? It's a certain something that went on in your area, or is the numbers that we're getting in other areas maybe not hitting all of the mental health disorders?
Two
It just
things.
seems inordinately high.
Yeah, two things. One is I don't mean to say 40% of the children in the school system. What I am referring to is 40% of the children that we see.
Okay.
Okay.
Of that subset.
Yeah. So understand that distinction. Do I think that we're unique in North Georgia in seeing those folks? Not at all. I think the fact that we have access to mental health services for children means that we're seeing more of them, right? Many of them go without professional care. And because we're there and we have access to mental health professionals, they're coming to see us. So I think you'll see those kinds of rates any place where you have access to behavioral health care for students.
Well, I think it's absolutely wonderful. We know for a fact that when you catch the mental health disorder early,
yeah,
that is when you can most affect change and a better outcome. It's when they're 17, 18 to 24 that untreated that we have significant problems.
There's no question about that.
Thank you again, Mr. Chairman. Chairman Perkle, I won't divulge my sources, but there are those that think that 40% number certainly applies to the legislature. I don't agree, but I've heard it. I just heard that. But that's so true, Chair Lady. Thank you, Becky, for all you're doing. Thank you for your years of friendship. I was listening, and there were some things that I found very, very interesting. But first, for the young lady from the Athens area, you're so right. I would have never known how poor Clark County is, because we always think about the middle and upper middle class employees here at University of Georgia. Nobody ever thinks about the inner workings. That was very interesting. But I'm very thankful for Diversity Healthcare in Liberty County. It serves Liberty, Long, and Wayne counties, and the impact it has on Jimmy's toothache when you have a dentist. It costs a ton at the emergency room, 1 o'clock in the morning, and because he's going somewhere with the pain, and it ends up being written off as bad debt. So it's a big help. We do have dental service there, and one of the least known things is this is not for poor folk only. It is fee-based. My dentist, former Senator Lester Jackson, was out licking his wounds from a recently lost statewide race, so I couldn't get him to see me. I needed to see him as a patient. But what happened was I went to Diversity and had a terrible wisdom tooth removed. And I had insurance, and, we just worked it out. But it's for anybody. It's just fee-based. And sometimes it's a quick resource. I've been very involved with the organization for several years now, and the more I'm involved, the more I like it. Because in rural Georgia in particular, it's sometimes ignored, because most of the folk that can really help don't have the problems they have. So not their fault. You don't know what it is to be hungry if you had never been hungry. And you don't know what it is to not have a doctor if you've always had one. And you folks serve those that have missed. The safety net has some big holes in it. And some people fall right through the safety net. And you all have served and served well, but you're really a well-kept secret, because there's still far too many people that don't know. But the dental, particularly Chair Lady Houston, it is so important, especially if you have a mobile unit. And we have a mobile unit, and it helps to be able to see. And as an aside, you can see a dentist on a mobile unit. You can't get a haircut in Georgia on a mobile unit. To my Republican friends, I will be trying to alleviate that problem in the coming session. But thank all of you for what you do.
This might be for you, Becky, or somebody else. So I'm learning about this, and I'm trying to follow the financial funding sources of what you're talking about. And I get one-time fee that helps get it started, and then one-time funding, and then maybe some fees charged. But I don't see a financial structure for me to understand how it works to be able to explain it to somebody.
Well, I'll start, but the
so
CEOs and their boards are the ones that really make it happen. And I will tell you.
But it, not just y'all, but you can't sell something if you can't tell what it costs and how it's going to work and what you need. And so I'm not able to piece it together based on what I've heard so far.
Okay, so thank you. I understand now. So to begin with, any patient that walks in the door is seen regardless of their ability to pay. And if they are uninsured or underinsured, they are charged on a sliding fee scale based on their household income.
You only got your seed money one time. What is sustaining you for 3 years down the road?
Okay.
Where is that coming from?
So the seed money is the capital dollars that are used to establish the infrastructure, to establish the building, to establish the office, to hire staff, etc. Then once you have the patients established, then you can bill Medicare, Medicaid, other third-party payers, state health benefit plan, for example, Blue Cross Blue Shield, any provider. And then many health centers do significant fundraising on their own, as Todd alluded to with the roast and toast that their superintendent allowed for. So the seed dollars are so critical because the operating margins are so thin. Once you've expanded services and you have that patient base and you can bill for more services, you can sustain it. But it's just expanding those new services that is the challenge. So for example, and Todd and I talked about this, and Dwayne and Todd and I talked about, going into a school-based health center, but we just couldn't find the capital dollars for Todd to be able to do that. This roast and toast of the superintendent, Dr. Bearden, allowed for that. It allowed them the seed dollars to begin operations. Then once they are in operation, it's not easy, Chair Lady Smith, but they do have to figure out how to sustain it. And then when there are expanded services, for example, dental services, when those are added, then the organization can apply for additional federal grant dollars to serve patients who are uninsured and underinsured. But I will let you all add anything
and I'll
else.
speak to that just not as a CEO, but just from the partnership aspect of it. So our school-based health center, again, was a strategic partnership between the Piedmont Athens Regional Foundation, who did give us a large grant, the Partners in Care from Emory, but also our biggest partner is the school in which we are housed in. The school provided all of the equipment. The school provided all of of course, the building, the maintenance. And so all that our federally qualified health center has to do is provide the staff. They provide the upkeep of the equipment. They provide, like I said, the actual infrastructure. So again, a lot of it is the strategic partnerships. If you start them early, some of that continuing infrastructure will be easier to maintain.
The support that we get from the school system is similar. They provide the facility and the space and utilities and all that, so we don't have that cost burden. The other part of your answer to your question is that 30% of our organizational revenue comes through a federal grant, which we receive on a regular basis. 70% of our revenue comes from fee-based services. So we're not a free clinic. We bill just like a traditional office to the insurance companies, Medicare and Medicaid. And so those monies account for 70% of our budget. And that's how we're able to sustain the operations that we have. Does that help?
Yes. So local taxpayer school dollars, in a way, if your school's providing it. So I'm just trying to anticipate all the questions one would get in trying
exactly. It's very similar for us. The way I explain it to people, yes, we're a mission-driven organization, but like Becky mentioned earlier, we're also a business. So it's interesting. The payer mix is a big deal for us. So if I said earlier, my uninsured rate's 45%, which is pretty high. If I got my uninsured rate down to 40%, I could actually see more uninsured people. That's the way the model kind of works. Does that make sense?
Yes. We have actually just a volunteer funded clinic called Good Samaritan, but it's not school-based or anything. And our county is more affluent, and it's just strictly through fundraising, and then they bill as they can with the different groups, but it's not enough.
Yeah.
Thank you.
One of the things that we will provide at the end of the presentation is a map showing you all the locations of the 35 organizations that I mentioned. So each color shows the footprint of that particular organization. And then the number corresponds with the name of the organization. So I'm glad to work with any of you individually to drill down a little more into what you see as being the needs in your community and how a health center organization may be able to fill those needs and keep those individuals from falling through the gaps, even though it is a safety net. As you said, sometimes they do fall through the gaps. And Chairman Perkle, I appreciate your question very much about the early intervention, because the data is astounding to show that through early detection, early intervention of mental health and behavioral health services, patients can learn how to cope with their mental health and behavioral health disparities, as well as keep them out of crisis. And what you've done through Speaker Ralston's House Bill 1013 and Speaker Burns and his leadership to continue building upon that progress will be tremendous down the road, because anytime that we can keep an individual from going into crisis, we have a better chance of getting them onto the road, on the road to recovery.
We're going to have to go on. Chair recognizes Chairman Matt Hatchett.
Mr. Chairman, Representative Williams, I think we're all need to be checked in for mental evaluation. I just, kind of going from what Becky just sort of said, we all know that so many times we focus on what's happening in our hospitals and the money we're spending and allocating toward hospital and Medicaid hospital. We lose focus that primary care is where we can prevent those costs from occurring. And thank you for what you do. In the school-based clinics, this may be just kind of a stupid question, but how do you handle the students with their healthcare needs when school isn't in session? Is there some special something y'all have set up, or just, I'm curious?
I think for us, again, it goes back to partnerships with that federally qualified health center. So our hours are during school hours and a little bit after, to capture some of those after school program students. But after that, we list our after hours as our other clinics, our other federally qualified health center offices, our other service areas who may stay open later. Our school-based health center is not open on Saturdays, but our other clinics are. And so we're able to fulfill that need by filtering them into other clinics as needed, but also partnering with other organizations, for instance, like Advantage Behavioral Health, for those students, if we are unable to provide services during the week for whatever reason, they can filter into an after-school program or a weekend program called Remix, where they are able to have those services. So again, partnership with a federal qualified health center, a community health center, being that safety net to filter those students into other offices if we're unavailable, I think is a key element to providing continued care and continuity of care.
Mr. Chairman, can I ask one follow-up? Just to follow up with that, I'm curious for each of you, do you offer what are called maybe extra hours or not normal hours, after hours services for each of you?
Yes, we do. And we also have 24/7 physicians always on call.
Yeah, we're the same way. We offer early hours and extended hours at the end of the day, and Saturday services, and we have a 24-hour call line for people to access at any time.
Thank you.
Chairwoman Till.
I was going to say our clinic is actually the busiest before school hours and right at the end of the day, because parents are wanting, their students not to miss school. So, the beginning of the day and the end of the day is typically our nurse practitioner is the busiest during those hours. Yes.
Okay, thank you. Thank you. Several things I wanted to talk about, and even to let members of the committee know, if you've seen one clinic, you've seen one. They are all locally managed and directed by what the community needs are. I've followed this ever since I've been in the legislature, and it is one of the best kept secrets, and it shouldn't be a secret. I can share what they've done in our community. We have OB problems like everybody else, and it happened to be a private entity. Centene put the money up to add a midwife, so we did not lose any OB care. And working within the community and the clinics, I get it that that wasn't part of the school base. Our school base does many of the same things that you do. And I think that it's important to understand they operate and run just like a doctor's office. They have the electronic medical records. If you're seen at the school clinic, you're seen at the school clinic. If you're seen down the street at the regular office, they've got the same record. They know you in your practice. But the other important part of it is they usually have the 340B access, which is a great savings for folks to be able to get their prescriptions at a very reasonable cost. Many things about this are growing. I think that's part of what it is. As this secret is getting out, we're seeing more and more requests for it. And Penny, yes, I am working on a mobile dental. I am working on that. So I do see that in the future. And another thing, we're talking about making these kids healthy right now. You're also laying a groundwork for these children to know and accept it's part of life to have health care and go to the doctors. You don't want someone 18 years old and never been to a doctor. So I think I have to commend you for what you're doing and the fact you've taken it into the schools, and I think it will make a difference for the future of Georgia's health care. Thank you.
I want to thank the panel for your compassion and the work that you're doing in the community there. And Becky, you know that you're our advocate when it comes to this type of responsible community action programs and things. You're always there as our resource person, and we really appreciate that. And thank y'all for what you're doing with us, and thank you for coming this morning and sharing. You can see by the questions there's a great deal of interest in this particular type of situation. Thank you so much.
Thank you for the privilege of being here today.
We will now hear from the Patients First Act update. Jesse?
Thank you.
I'm good. Jesse, we appreciate you coming this morning to update us, and we are ready for you at this particular time.
Yes, sir. Thank you, Mr. Chairman. Good morning. My Chairman Green, Chairman Jackson, members of the Rural Development Council. It's a pleasure to be here in Athens at the University of Georgia, go Dogs, and to be back in front of the Rural Development Council. Last time I spoke in front of y'all, Chairman Hatchett had to remind me to talk a little bit more slowly, so I'll try to just do that at the outset and save him the trouble. My name is Jesse Wethington. I'm the president and CEO of the Georgia Association of Health Plans. I believe I've had the pleasure of working for or with many of you in the past, but if I have not met you, good to see you. The Georgia Association of Health Plans is the state's trade group that represents the commercial health insurance carriers within the state of Georgia. Rural areas, of course, have traditionally been one of the more challenging areas for carriers to offer coverage within the state for many reasons that you've heard about or are probably already familiar with. Bad outcomes, few providers, expensive care, and economic challenges that make it difficult for individuals and employers to afford access to the few healthcare options that are actually available in their communities. Either that or you got to drive a long way. So it's no secret to you all that, or anyone else in Georgia, that that Georgia has many healthcare challenges, and that those challenges are more acute in rural areas. This council has spent many years studying those challenges, in fact, in the last few months hearing about many of them. So with the instructions from the chair in mind, I'm not here to give you all the civics presentation about health insurance carriers or what we do as an association, but here to tell you all a little bit of a success story and identify some issues that may be on the horizon as relates to the affordability of insurance and the future of the Patients First Act. I call it the sleeper hit of the decade, better known as the Georgia Access Reinsurance Program. which is part of the Patients First Act, or Senate Bill 106, from way back in 2019, 5 long years ago, before anybody had heard of COVID-19. Y'all remember those days? I will share some information related to the other parts of the act that have to do with commercial health insurance, that being the 1332 element of the Patients First Act. But first, I really should talk a little bit about health insurance, who has it, who's paid for it, and how those trends have kind of changed over the recent past. So first, a note about some of the numbers I'll give you in my presentation. I'll be sharing with you several sources of numbers around sources of coverage for enrollment figures. There aren't very many good sources of data, even few that are recent, and the public health emergency and several other policy changes that have occurred in recent years, and there have been many, have scrambled the picture to a degree that we're kind of just coming to grips with, particularly as it relates to public insurance. And so some of these numbers are estimates. Some of these are snapshots at a point in time in a year where there was high volatility. And most of these will tend to undercount the number of people that are on Medicaid due to the maintenance of effort provisions that were in the public health emergency as a requirement of taking COVID-19 money. Some count the Department of Defense coverage as a separate category. So just bear that in mind as you see some of these different sources of coverage. What they do depict, and generally are, is indicative of the trends and the proportionality of the sources of coverage over the recent past. This graph shows the relative proportions of sources of coverage in the year 2021 in the state. So for instance, the employer-sponsored and coverage group, that includes both, the ERISA large national plans, as well as small and large group employer-sponsored plans that are regulated by the state, has comprised a little more than half of the covered individuals statewide for the better part of a decade. Medicare and Medicaid have been in the mid-teens, kind of again, not counting that COVID spike from 2020 until this year. And the individual or non-group market has been growing at an increasingly rapid pace, while the number of uninsured Georgians has decreased. The latter two trends bear directly on the remainder of my comments and the Patients First Act itself. So this next graph shows you a little bit of the recent history, and this is the sort of absolute enrollment rather than the percentage and where the sources of coverage are. From the years 2018 to 2022, again, skipping 2020 for obvious reasons. At the bottom in blue, you will see the employer-sponsored coverage group, again, holding steady at about half of the population. Next, up in orange, you will see the non-group or individual market. This group includes the folks on the exchange, and most of the remainder of my remarks will focus on this group. Up above them in gray is the Medicaid population, which again is undercounted post-pandemic here. The source of information is the Kaiser Family Foundation, which uses American Community Survey data from the Census Department. Next up in yellow is the group who is on Medicare, and the smaller group in light blue above that is another federally funded insurance pool of insurance. Those that are covered under Department of Defense program, like I mentioned earlier, they were counted on the previous slide in the employer group. They're counted separately here. And on green in the top is the uninsured population. But as they say, what is uninsured is self-insured. This group is also not homogeneous. There is a persistent, for example, there's a persistent high-income group with household incomes above 400% of the federal poverty level that for some reason does not purchase health insurance coverage. The main things to spot and keep in mind from these trends is that since 2018, the number of Georgians purchasing on the non-group market has grown, the number of uninsured has decreased, and the number on Medicaid has swollen due to the prohibition on eligibility redeterminations that ended this April. So this next graph depicts that slice of orange from the previous slide. So this is the Georgia enrollment trends on the marketplace from the year 2014 to the year 2023. As you see, the growth in this segment of the market has really taken off in the last few years. And as you will hear, this actually is probably a low figure for 2023, and 2024 enrollment could easily surpass 1 million individuals for the first time, or covered lives for the first time. This rapidly growing non-group segment of the market is the focus of both phases of the Georgia Access Program, to which I will now return. So a little bit of history for y'all. Way back in 2019, as I said, the General Assembly passed and Governor Kemp signed into law Senate Bill 106, which is the Patient First Act. It allowed the state to apply for what is known as a Section 1332 State Relief and Empowerment Waiver, as a waiver from that's implemented under the Affordable Care Act. And so what those do is they allow states to implement sort of innovative strategies to deal with coverage affordability that the ACA did not necessarily contemplate, and it allows for experimentation. And again, it's in the title, State Empowerment Relief. The other part of that Patients First Act was an 1115 waiver, which is known as the Georgia Pathways Program. My comments today are primarily about the commercial insurance side, which deals with Georgia Access. So the intent of the program was to set up a reinsurance program that would allow for increased coverage, to promote more competitive private insurance marketplace, and to reduce premiums. Georgia received approval for the program November 1st, 2020, but because of the COVID-19 epidemic, the implementation date was pushed back a year. So a little bit more about 1332 programs generally and how ours compares. There are 16 states, including Georgia, that have implemented a reinsurance program as an element of a Section 1332 waiver. The programs differ pretty widely in terms of design and their funding methodology. For a attachment point type co-insurance model like we have, policymakers will identify a target for premium reduction, and then they'll use actuarial modeling to determine what amount of reinsurance financing would be required to meet that target. The next step is they calculate how much federal pass-through funding will be available to offset that required amount. And finally, the state leaders must determine what funding level is desirable and within the state's budgetary constraints to fund the rest. The second piece of the 1332 waiver, part two, is known as Georgia Access. So this was originally intended to transition shoppers in this market away from healthcare.gov, which is a federally facilitated marketplace run by the Department of Health and Human Services, to a more private environment where private brokers, navigators, or insurance carriers directly would be able to enroll consumers in their coverage during the open enrollment period instead of shopping on healthcare.gov, as this group has done since the passage of the Affordable Care Act. Unfortunately, there was a series of disagreements between the state and the federal governments about implementation there. And so the state has now decided to implement a different strategy to go with a state-based exchange. And to that end, Senate Bill 65 was passed by the General Assembly this year and signed into law by Governor Kemp, which allows the state to set up and run a state-based exchange, which will give us a little bit more flexibility and control over the operation of the program and how both those enrollment vendors, individuals, carriers, brokers, and navigators all interact in that environment during open enrollment. So, however, despite the progress that the state made doing that, CMS disagreed with our ability to operate a state-based exchange fully this year. So for open enrollment 24, we are still using healthcare.gov, and we hope the state will be able to transition to a fully state-based exchange for open enrollment 2025. So let's dig a little bit deeper into Georgia's reinsurance program itself. These are some numbers from program year or plan year 2022. Again, these run on a calendar year because open enrollment, you sign up for benefits this time of year, and those benefits become active on January 1 and run through December 31 unless you have a qualifying event or get coverage elsewhere. Yes, sir. Thank you. So Georgia's program is a traditional reinsurance program. The attachment point initially was $20,000 up to $500,000. It is a three-tiered co-insurance structure with the rates of 15, 45, and 80% tiers based on a geographic ration area. And so the design is that in the higher cost areas, particularly rural areas, the co-insurance amount is higher. So that would be the 80% areas. Initially, this program was seeded with $92 million in state funds. That is 23.1% of the total. Those are state general funds. The federal funding initially was $306 million in pass-through funding, or 76.9% of the total. The federal fund source for these is basically savings that the federal government would pay on the advanced premium tax credits that folks get on the exchange now. 94% of people who purchase insurance on the exchange get a tax credit from the federal government to defray the cost of the premium. And so these folks are no different. And so what the federal government does is it takes the savings they would have paid out on those higher premium tax credits, and they basically swap it out for this pass-through funding to the state to run the reinsurance programs in the 16 states that have them. So again, above the way the attachment point in the cap works is attachment point is $20,000. So above the cap, above the attachment point and below the cap, the coinsurance applies. Below the attachment point and above the cap, the insurer is still 100% at risk for the cost of that claim. So wanted to share a success story with you all. So we'll talk a little bit about the results thus far. Premiums have been reduced by an average of 12% statewide. This represents an average of $850 in annual savings for Georgians shopping on the exchange. Rural communities have had the greatest impact. Rural counties where premiums are the highest, premiums have been reduced from 25% to greater than 30% in some communities. This is because the coinsurance rates are higher in those rural geographic ration areas, as I mentioned. There are more carriers in the market, more competition between them. In 2019, Georgia only had 4 insurance carriers selling on healthcare.gov. In 2022, there were 11. 2024, there will be 9. Consumers have more choices. In 2019, only 26% of Georgia's counties had more than one carrier offering insurance on the individual marketplace. Now, 98% of all counties have more than one carrier, which means dramatically greater access in rural and underserved areas. Most counties have more than 5, and only 3 counties remain that are still only offering a single carrier on the exchange. We've reduced premiums and expanded choice, and that has led to increased enrollment. In 2019, only 373,000 Georgians were enrolled in the individual market commercial plans. As of July 2023, and so this is data from the Department of Insurance, there are currently 945,000 Georgians who are getting coverage off of the exchange. So that's 921,000 are on the exchange, and there's 24,000 still in the individual market that are not. So it's a really, really small subset of this group that are not on healthcare.gov. The market has grown a total of 21% since January, from the 6-month period from January to July 2023, for an average monthly growth rate of 3.25%. And more consumers have coverage. Since 2021, the uninsured rate has dropped from 13% to 11%. So the stated goals of the Patients First Act were to reduce premiums, entice carriers into the market, and to give consumers more choice. A resounding success on all 3 fronts. Premiums are down significantly, particularly in rural areas. The number of carriers on the market has more than doubled, and the number of covered lives has more than doubled and is continuing to grow at a rapid clip. Y'all, this is even good news for providers who now have 3 or 4 carriers to contract or not contract with in their communities compared to the 1 that they had before. But there's a lot of words on this slide, and if you remember one thing, I'd rather it be the pictures I'm about to show you, which really tell the story a lot better. So here we have a heat map, a series of heat maps above that depict the number of carriers showing coverage in counties, or number of carriers in counties. So on the left, we have the state's picture in 2018, a cluster of blue around Metro Atlanta, which is where the only real choice in carriers was available in the early years of the exchange. The Patients First Act, as we've said, was passed in 2019, and we began to see carriers start to enter the market. By the first year of the program, 2022, the picture has turned blue. In 2023, we have only 3 remaining counties that are offering coverage from a single carrier, where coverage from a single carrier is available to the non-group market. This is also a picture we don't really see when we talk about healthcare issues in Georgia, because it's a picture of 1 Georgia, not 2. And so y'all did that with the passage of this act, and you all should be commended for it. Like I said at the beginning, this has been a healthcare success story of the decade, in my opinion, and I feel like that story is not necessarily being told. So thank you for giving me an opportunity to tell it. Just for reference, Toombs, Treutlen, and Montgomery County are the only 3 left with a single carrier. So room to improve. So As per the chairman's instructions, we were also asked to identify some challenges on the horizon, so I'll share a couple of those with you all now. So program parameter changes that are coming in the next year, these were communicated early to us by the Department of Insurance, and so they involve a change of the attachment point by increasing it to $30,000. This is simply to deal with the growth of the program. These claims are also subject to healthcare inflation, and so the cost of the program has gone up as more people have enrolled, and the exposure to the risk of the health insurance claims that we have to pay generally is included in this. See, we are fairly agnostic as an industry about the specifics of what risk band or where the co-insurance rate is. In a competitive market, this is basically used to buy down coverage cost dollar for dollar because the carriers are competing with one another for those enrollees. And I will tell you, the unsubsidized healthcare.gov shopper is the most cost-sensitive consumer in the healthcare marketplace today. So these folks are really looking for the lowest cost plan that's available for their coverage. Or lowest cost of premium, the premium and then the total out-of-pocket cost with the deductibles. These make sense, like I said, these changes in the attachment point make sense to control the growth in the program due to enrollment because healthcare inflation affects this as well. So the next piece is sort of what I mentioned before. We're in what I like to call the halfway house this year on the state-based exchange or the federal facilitated marketplace where we've been allowed to do a state-based exchange federal platform this 1 year, and then we'll transition to a fully state-based exchange next year. The Department of Insurance has already done a lot of legwork getting the Georgia Access program set up on the back end, and so this really just gives us a little bit more time for implementation. There's also a lot of certification and process that brokers, agents, people like in that part of the industry have to deal with. So they can do that now and get ahead of the curve for next year, but we are in a little bit of a holding pattern until 2025's open enrollment next year, but that kind of is what it is. There's still a lot of room to grow in this market. We think about 500,000, a little bit over 500,000 Georgians are eligible to purchase insurance on healthcare.gov, but for whatever reason have not done so. And again, 94% of those people can expect to receive a pretty hefty savings on their premium from an advanced premium tax credit. So there's room to grow. And last and key issue for our industry and what we would like to be the takeaway for you all is marketplace stability issues are the biggest challenges from an industry perspective. 2 carriers were declared insolvent and taken into receivership this year. That's why I mentioned that the number of carriers is dropping from 11 to 9. So those were Bright and Friday Health Plans, neither of which are members of Georgia Association of Health Plans, I'll note for the record. But those plans also were carriers that participate in the exchange market have to pay risk adjustment payments into the large pool. Obviously, those companies being insolvent, not having enough capital to cover the cost of their liabilities has led to a haircut that the entire industry will take. And that's just sort of a facet and a reality of doing business in the exchange where there's a corporate insolvency. However, that happened twice this year. And so, and one of those carriers too had a pretty decent sized presence in the market. So we're kind of dealing with the fallout from that. So those have left a hole in our risk adjustment payments this year. And so the second piece, and probably critical for us and for this group because the state policymakers can affect it, is that the level of funding for the state share of the reinsurance program must be adequately funded on a prospective basis in a given plan year. The way that the timing works on this is a prospectively funded program. The federal government tells us the amount of pass-through funding that will be available around September of every year, I think it is. And so, if I could leave you with one thing, that this is not like the Bank of Medicaid, where you can borrow from growth and then say, we'll get you back in the amended. Because what happens in this program, because of the timing of the budget, the calendar year, and the state's fiscal year ending in the middle of the year, that can lead to funding shortfalls. And so what happens then is carriers in the marketplace take a haircut. It's post period, so we can't do anything about it. It's just, this is it, deal with it and book it. And so insurance carriers really don't like volatility or instability. And what happens when those things are introduced into a market is that they get priced into the premiums. And so we would urge you to fully fund the reinsurance program at whatever level of state funding is appropriate to meet those targets for a year. Otherwise, what we will see is premiums start to go in the other direction as risk kind of re-enters the market, and insurance carriers will have to price for those in advance if we cannot be confident that the state will be able to fund the amount of the program as it was projected to be in a given year. So lastly, the other big challenge on the market, and I really want to focus on commercial insurance, but this does have an impact on it, is the current trends with Medicaid redetermination. Georgia began its unwinding process in April of this year because that's when the maintenance of effort provisions in the COVID-19 bill were waived by the federal government. More than 10 million individuals have been disenrolled nationally as of November the 1st. Georgia has elected to do a 14-month redetermination window, which is not particularly aggressive. Some did it in as few as 6 months. So Georgia's kind of taken a middle-of-the-road approach there. And I will say that no state has really mastered this or is doing a great job compared to any other. Everybody is kind of dealing with this unprecedented issue all at once. So as of July, 45,000 people have transitioned from Medicaid onto a qualified health plan onto the marketplace. So from Medicaid to a commercial health insurance product. Nearly all of these individuals, because they're probably lower income, will receive an advanced premium tax credit, so they'll be paying a very low premium every month. And approximately 20,000 individuals are pending eligibility determination for Georgia Pathways. Approximately 40% of the folks who have gotten onto the program who have applied have gotten on the program now. So that means that there are several thousand more people in the pipeline. And of course, DFACS and Georgia Gateway are processing those applications as fast as they can, along with the 220 some odd thousand individuals every month who are getting redetermined. One carrier that's present in the Medicaid marketplace nationally expects as many as 2.4 million of its 15 million Medicaid managed care members to lose coverage during the unwinding process. But they reported that more than 1 million customers had enrolled in the exchange policy during that last year. So a lot of these folks are not losing coverage, they're transitioning to a private product. Again, not everybody who's disenrolled is going to be uninsured. So I'll leave you with this. No one has any clue how many people are going to be on Medicaid at the end of this process. The unemployment rate is between 3 and 3.7% in some areas of the state. And so you would expect for a means-tested program to lose enrollment. Medicaid has traditionally been a counter-cyclical program, so when unemployment goes down, Medicaid rolls also go down. And we have just stood up these additional programs, and so it's still early days to kind of see where the coverage amounts are going to shake out and who's going to wind up on what process. And so the picture remains cloudy for the foreseeable future. However, what is not in doubt is the success of the Georgia Access Reinsurance Program, that it is meeting its stated goals. And so as the health insurance, we in the health insurance industry would like to ask you to continue to support the success of the Georgia Access model, ensure it's fully funded in the future to lock in the gains that have been made already, which are particularly sweet for rural consumers. So thank you, Mr. Chairman. Mr. Chairman, appreciate the opportunity to be here.
Well, thank you so much. It's a very interesting slides that you have presented there, and it certainly gave us an understanding of to a certain degree. I'm not one of those individuals that understands all of this, but you've made it through your slides something that we can see there. We do have some questions, and I'll ask you to limit your questions to just one, please, and not a statement, but a real question. Representative Al Williams, please.
Thank you, Mr. Chairman. If I ask my question, I promise, along with my colleagues, that we're not going to let the folk in your district know why we drank regular water. You have Perrier in front of you. We're not going to mention it. But I've heard what you said about, and I'm eliminating several questions based on the request. What you said about DFACS doing all they can. I think in Statesboro we proved that that's not so. They are not responsive when they won't even answer a representative's call. I don't know how they're doing all they can to re-enroll people. It's a disaster how many calls I get. People are not on Medicaid, can't talk to DFACS because you can't find anybody but a robot who's probably in Afghanistan. Just wanted to make that.
Well, Representative Williams, I am fortunate to not be able to speak for the Department of Human Services or DFACS today.
Thank you very much. Representative Clay Perko, Chairman.
Thank you, Mr. Chairman, and as always, I hate to follow Al Williams. Is that not true? Your question as a statement. So the reinsurance program is fairly expensive. $400 million, give or take, just a bit. The question I have is in two parts. One has to do with the number of insured people that are not under a Medicare, Medicaid, nor under the employer sponsor, but that independent group that we're targeting here. Does that only include those that have the commercial insurance, or does any of that have to do with this Medishare stuff, or is that counted as uninsured?
I wouldn't think you would count anybody who only had like a Medishare plan as an insured, because that's not regulated or considered insurance by our department. So that's really that. It's about 800,000. If you look at a source, would be that group of people. We think based off the growth in the exchange this year, it's closer to like 580,000.
Okay. So where does the savings come in? Are we just taking out of one pot of money to subsidize? But it appears that we get more bang for buck than that. And as an economist, I love to see more competition. You add more companies in, the price will go down. We know that for a fact. So I don't understand, outside of just, unless it's for the companies that see a more consistent revenue because of the state reinsurance program, that's the only method I see in the savings that we should materialize.
So it's a good question. And the quote unquote savings to a public treasury would really come from the federal savings on offsetting the advanced premium tax credits that they would be paying out to those individuals who would be purchasing insurance.
But we also pay that, though.
Correct. To the state treasury, it's merely an expense. I mean, you have decided that the $92 million in state general funds that's matchable at whatever rate the federal government will do is worth it, quote unquote, to meet this public policy goal of reducing premiums by X amount percent, getting however many more 100,000 people in the marketplace or more carriers into the marketplace. But in terms of a offset or spending reduction, I wouldn't characterize it like that. This is about really moving money around within the system and focusing savings on individuals who are kind of getting taken to the cleaners before.
Well, the ancillary benefit was adding additional providers, because there again, even if you were moving money around, adding more providers will provide a lower cost.
Correct. And for us having additional members in that market, I mean, we can spread the fixed costs of operating a health plan over more people. And so it's good from that perspective as well.
All right. Chairman Bill Werkhauser.
Thank you, Chairman. Won't call out by name, but I'm on a local hospital board, got like 4 rural hospitals. Because these contracts for these providers are done individually, I got a hospital who gets near or below Medicaid, Medicare rate from a provider that from a hospital 15 minutes away gets 6 times the rate. If we got 1/3 of the way there, we would be flush with cash instead of struggling month to month. How do we fix that?
I would say, and the issue is going to be in not knowing the particular area that you're talking about. Smaller entities typically have lower bargaining power. It's just a reality of the marketplace, and it's not any different.
We have 0.
In the healthcare marketplace, unfortunately. If those are critical access hospitals, they do have a little bit of a different payment structure, particularly from the publics that should deal with it. But in terms of, what one hospital is able to negotiate with another contract down the street, I'm afraid I don't have a good answer for you. I think you'll continue to see that, but that's just part of the tug of war between insurance carriers and hospital systems. They get bigger, they use their market power. We get bigger, we try to use our market power, our growth in enrollees to get a better bargain. You know, I would say from our perspective, we don't necessarily think it's a great thing to pay 6 times as much for, you know, the procedure down the road, but that hospital may have had some other means of negotiation where they're able to get an advantage. And typically what you'll see is the contracts are negotiated globally, but they'll focus on maybe one cost center where they're able to make a decent margin, or they're trying to attract, you know, a physician or something that could be a marquee service for the community. And so a lot of times the negotiations will kind of hinge on, well, I want to make more in this part of the building. Okay, well, you got to give me a little bit less here, but without knowing more, I just hate to comment on a situation I didn't have more
Basically,
detail.
just restated the problem. Thank you.
Representative Lisa Higgins.
Thank you. This was a lot of information, and thank you for bringing it to us. And it's not my area of expertise, so if you already covered this, I apologize. And you do talk quite fast, so maybe I just missed it.
Try to work.
But so 3 of those counties that you said only have one carrier. 2 are in my district, and the other one is in my neighbor's district. Why do you think it is that they're the only 3 out of 159 counties that only have one carrier?
I'd just be speculating, but
That's fine.
I would assume that's a rural area. There's probably a dearth of providers there, and so.
What? Yeah.
So I think it probably would just be a challenge to contract, and so, you know, I think we can maybe hope to get carriers in those counties in the future. As to why they're not in those 3 particular counties, and I mean, they are clustered together, so it would seem like it would be the same set of factors that would have led to that outcome. You know, I would be speculating if I said why it was just the one that, and I'm presume that's probably the one that's been statewide the whole time. That's offering there. I'd have to go look and see what the carrier was, but that's just kind of a decision that one carrier made. It's like, we want to kind of dominate the exchange market, and to do that, they had to be in 159 counties from the outset.
All right. Thank you.
I would love to come back in 2 years and talk about the 4 more carriers that have come there, and I hope we will.
It's probably your district, right?
It is. 2 of them are in my district.
I thought so. Chairman Taylor.
Thank you, Mr. Chairman. Thank you.
This is our last one.
Thank you for this information. It is.
Save the best for last.
Yeah, thank you. This is very good information, and one of the things I'm concerned about a little bit is I think we're going to see more ICRAs come out. That is the new little individual market, the ICRA plans. I hope everybody is sort of predicted for those. I've seen a concern of, I guess it's not having enough reserves. That's what happened to those 2 carriers that went under. And one of the things that I've seen is during COVID, people did not go and get the healthcare treatments that they needed. So now they're getting them, and instead of stage 1, they're stage 2 or 3. And also, we're now getting the normal people that would have just had their checkups. So it's double the trouble. I guess that's what it is. And are the carriers reserving enough and predicting these increased costs?
So that's definitely on the horizon. We're all experiencing that. So you've heard of revenge travel. Revenge healthcare is definitely a thing too. So this pent-up demand is happening. At the same time, you know, the healthcare is subject to the Dutch disease, or labor cost growth. And so there's everybody who is in the production factor of this is having their labor costs go up, and they are turning to us for increases to pay for those increased labor costs as well. And so we're feeling that from the pent-up demand, the higher acuity, and the increased labor cost for everybody that we contract with.
Just as long as everybody's predicting it and counting for it. The other, and I've said this before, we're building it. The state is investing money in everything from residency to clinics. If you build it, they will come. But if you don't pay them, they ain't staying. We need to make sure that our payments are right. Thank you.
Thank you, Madam Chairman, on that. Jeff, we really appreciate you being here today. That was some wonderful presentations that you made there. And we'll be asking you to help us in December when we do some of our proposals and things. So thank you very much on that.
Mr. Chairman, members of the council, thank you very much.
We have lunch in the Magnolia Room, and there's enough food for everyone, including our guest speakers and the audience, to come in and have lunch with us in the Magnolia Room. So we're adjourned for lunch, and we'll be back here at 1 o'clock. So eat quickly.
Figure out what.